those who are in India, and all my students, final year students and the postgraduates who have logged in particularly, and all those friends who are in the United States, very good evening. And this series of education is continuing. And like I have told you earlier, there are two pillars for this educational program, Dr. Sridhar Chilamuri and Dr. Kairam Mohan. And both of them have been doing exemplary job in handling this particular situation. So I was discussing with Dr. Budraj earlier that I want to know whether this is being translated into the patient care. And I'm very glad to know from Dr. Budraju that he has been talking to people over here in India and finding out the difference after they listen to these talks. I mean, that's very soothing for all of us, and that's what this particular forum is meant for. And as today's speaker is Dr. Sridhar Chilamuri again, because whenever we need help or when we are going through a tough time, we always invite him to deliver a lecture so that lecture and interact with us so that it makes a little change in our approach. And he has readily agreed in doing this. As you all know, that he is the chief of medicine in Bronx Care, New York, and he is a master trainer. He has many residents, hundreds of them he trains, and he is into the medical education for the last 30, 35 years. So without wasting much time, I invite Dr. Sridhar Chilamuri to go ahead and make his presentation for a few minutes and later answer the questions. Thank you, Sridhar. Over to you.
Yeah, thank you, and good morning to you all. One of the things I want to mention that COVID is a relatively new disease. It's only 1 year old. So if anyone tells you they're experts, I'll tell you they aren't any experts in this field at all. So that it's a very humbling disease. At various points, you have to look at the data that you have, look at the emerging patterns of illnesses, see how your protocols are working and recalibrate and see some of the things that become perhaps dogma or everyone says this, therefore we are following. And it is not that disease, because I think each of us are learning every day. So, so the last 3-4 days I've been watching what's happening in India. I've heard presentations across the country, panels, even in this panels we discussed it. But it set me thinking, and I said, maybe we want to go back and look at what we are saying and what we are doing. Is that really different? Is that actually helping patients or not helping? So I went back to basics, and I did in the last 3 days, went back to our own data. We have, from our experience, 2,700 COVID positive admitted moderate to severe patients, and we have another 2,700 or so patients who were presumed to be COVID positive. That's our database, and then we have a database from Italy and also from Colombia in South America. So, so we use about 20,000 patients or so constantly, go back and see if it made sense, and is it compared to what you are seeing there and what we saw here in Europe and then here in North America. So I went back to study that and see if I can make this slide move. Okay, let's try it. Okay. So the main questions I wanted to ask myself and look at your data as much as it's available. Unfortunately, we don't get enough information. There are about 25 or so publications from India right now of mucormycosis. And so we have some insights into it. Rest of it is all in the lay press, and we would like to see more of it and see what you're seeing. Is it any different from here? So the number one question is, COVID in India different than in what we saw in the rest of the world? Because you're seeing so much mucormycosis. And my answer is it's not. I think the disease is essentially the same. Maybe the variants are somewhat different. more and more, it looks like it's not the Indian variant that's spread all over the country. It could still be the UK variant. I wish we had more data from India to see which variant is actually dominating India. But be it the UK variant or the Indian variant, I don't think as a disease it has changed a whole lot different than what it is here in Europe. I wouldn't have said that 3 days ago, but I went back and looked at our data and saw things that are clearly what you are seeing there. So I think the disease is very much the same. Now, in terms of opportunistic infections, you have mucormycosis. In Europe, it was aspergillosis. In the United States also, it was aspergillosis. And I went back to my data sets and I saw we did have a spike of candidemia. So opportunistic infections were fairly common in the United States and Europe too. There's a very well done study in Wales, UK, where all patients who were admitted to the ICU who were fairly sick, moderate to severely ill patients, and then divided them into 2 groups. And in one group, they aggressively looked for fungal infections. In another group, they did the routine way of how you look for fungal infections. And when they aggressively went and found them, nearly 26 to 30% of severely ill patients in Wales had aspergillosis. So it was fairly common in Europe too, not so well reported until now. And when they looked at those 20, 30 patients percent of patients who had aspergillosis, 50% of them died. We also in the United States saw nearly 40 to 40% of our severely ill patients die in the first wave. And they died fairly rapidly. We didn't even have an opportunity to see if they had fungal infections or not. So my main point is fungal opportunistic infections are fairly common in the US and Europe too. It's a different fungus that you're seeing in India, but I'm not surprised that you're seeing it. We saw something different. I think how we do clinical operations is a little different, and I'll comment on it in the end. The other thing is that the treatment protocols that you're using in India, have they in any way contributed to your excess amount of mucormycosis? Perhaps, and then we should look at that, and I'll comment on that. And then the second thing is that do the viral variants that you have in India, being slightly different than one we saw in the US and somewhat different than UK, do they actually lead to different clinical syndromes? So every data set that I looked, where we looked at certain T-cell responses or antibody responses, we see no difference. So I don't think the variants, the only thing the variants do is they give a better ability for the virus to attach to cells. As a result, they become more transmissible, but there is no real data that the disease presents any differently. So I'll caution you when you say it is presented in 3 to 4 days or 5 days in this wave. I am skeptical. This is how I look at clinical medicine. You have to be skeptical about what you're saying and what you're observing. So you want to be more meticulous, because as I show you in the next few minutes, the timing of that steroid is such an important thing. So let's not believe that this disease is somewhat different in India. I don't think it is. Right now, I think it's behaving exactly like everywhere else. So what are these risk factors? And I won't go into a lot of detail. You must have already heard enough of this. But I want to focus on the risk factors as it relates to COVID. Is one, you have T-cell responses, which are somewhat abnormal in COVID. In India, what we're seeing is a majority of patients who COVID so far have I just want to see. Okay, they're just questions. Okay. Majority of the patients that we saw in India are male, and that remains to be explored a little bit. And by the way, diabetes is a common risk factor, but not everyone who had mucormycosis in the 26 or so cases published in various reports had diabetes. So this not alone is a risk factor. And the role of steroids, I want to discuss a little bit. And something that we haven't talked about at all is iron overload, which is a risk factor in COVID. And I want to bring that over as we discuss COVID, and then contamination of medical supplies is something that we can talk briefly and see if that makes a difference. So let's go to the T cell responses. So we know, when you have a COVID disease, you have CD8 T cell responses and CD4 T cell responses. When you have mild disease, a pattern emerges, and when you have severe disease, a different pattern emerges. Trying to get pointed. So with the mild disease, the pattern is totally different. And likewise, when it's a CD4 response, it is equally different when you have mild disease, and when it's T cell, when it's severe disease, the CD4 cell response is quite different. But it's very important to remember, to point out, is that T cell responses are dramatically suppressed when you get severe COVID disease. So much so that the germ cell centers are completely depleted when you have severe COVID disease. And what you find is exhausted T cells or lack of helper T cells, and then also suppressed T cell CD4 cells. As a result, by the time a person recovers or starts getting better from COVID, if he or she were to recover from severe COVID, he or she has barely any T cells left in their system. So that creates the right milieu for you to develop various fungal infections, including mucormycosis, and I'll show you. So what I did was went back to my database. This is last 3 days. Went back to our database to see what were the T cell responses in our patients when we had COVID in last year in 2020. The numbers are much lower now. Firstly, the T cell studies were not routinely done as part of COVID. Indeed, why would you do it? But we somehow managed to do 50 patients, and we followed them because they are HIV positive, although all of them were well-managed HIV patients, meaning very low viral loads and nearly normal T cell responses, T cell counts before they got COVID. And so we found 50 patients like that. So out of those 50 patients, when they got COVID, 24 or nearly half of them had severe lymphopenia. And then what to our surprise, we saw that the CD4 cells significantly dropped after they got COVID, and the CD8 cells also significantly dropped. And another thing is when the CD8 cells were below 150, out of 6 patients that we found, 5 died, and equally, when the CD4 helper cells dropped by less than 200, which would become age-defining, but this is due to COVID, 9 out of the 21 died. So we went back and said, okay, let's see if we have more information on the same group of people. So we looked at, we found 6 patients who we had T cell data on them before they got COVID, and then what happened when they got COVID at the time of COVID. This is approximately, I would say, 14 days after the onset of symptoms. So these labs or these T cells were assessed about approximately 10 to 14 or maybe up to 20 days after onset of infection. So these are CD4, CD8 ratios. So pre-COVID, this patient had 795 cells of CD4 and 1,400 CD8 cells. They dropped down to 145, and the CD8 dropped down to 584. Similarly, you see drops in every patient. And when they dropped quite dramatically, as low as this one, if you can notice, he had normal T cell counts of 5 or 9 pre-COVID. And when he got COVID, the T cells basically virtually disappeared from him, and all these patients died. So COVID was behaving like a hyper HIV infection when it happened. So, which raises the question, is it steroids, or is it something else that's happening that's raising the extraordinary rates of mucormycosis? So I would argue that depleted T cells are playing a very major role in the number of patients who are getting COVID in India. That's my number one observation. The second one is to understand mucormycosis. We no longer do mammalian animal species to study it because of cruelty to animals. So we only use now, so no longer mice models are being used. So we're down to zebrafish as a model to study what would happen if you infect zebra. And it's an animal model which is very similar to how human disease progresses. And so they developed two types of spores which you inject into a zebrafish. One has been radiated so that the spores don't grow well and actually don't grow well at all. And the other one is normal spores which will grow quite effectively. And what they found was if the type of spore, meaning the size of the spore and the inoculum, predicted who will live and who would survive. So when you inject this type of spore, which is a smaller spore, doesn't have virulence, almost all the zebrafish survive. And when you injected a virulent spore, almost all of them died. And you could see macroscopically, this is normal zebrafish and this is the diseased zebrafish. And then they slice the animal and look for various cell infiltrations. You could see filaments of mucormycosis and then these intense neutrophil responses. And so this was a good model to study how mucormycosis actually behaves in animal models. And so, so from that zebra model, what we are now, we have some insights. One is the size of the spore that we are dealing with. We don't know what subspecies is dominating in India, but the size of the spore and the inoculum appear to play a role. And the second thing is the spore on the mucosal surface itself does not in any way generate an inflammatory response. So the spore has to germinate and the filaments have to grow into tissue before you get any inflammatory response. And then the most important cytokine response appears to be interleukin 1B, which is significantly depleted in post-COVID patients, at least patients who have severe COVID. And so this is another thing that stands out in post-COVID patients. And the last one is normally, normal zebrafish, they get a robust neutrophil response. And so it begins to raise questions. What is the neutrophil count of these patients who had just got severe COVID? Do they by any chance have depleted neutrophil count, or is it normal neutrophil count? And why are they not getting a profound neutrophilic response? You're supposed to get it if you're normal. So when they get this disease, instead of having a robust neutrophil response, maybe they're just getting mild or no response at all. So we have to go back and look at these COVID patients who have mucor and see what is the neutrophil count. So if it's not working well, that they're indeed not putting up the kind of neutrophil responses you need. So that would be an area that we could work on. So we have something that could stimulate neutrophils, and maybe they are worth looking at. The next one is the role of steroids. So are steroids really making matters worse? And if so, how are they making matters worse? Because you have to understand that the doses of 6 milligrams of dexamethasone, if that were the doses that we're supposed to give, rarely will ever give mucormycosis. Mucormycosis, if steroids alone is the risk factor, is much higher doses than this. Of course, in India, high doses were used, but it's not clear to me only those patients got mucor or is it someone else. So we'll have to go back and study it. So how would steroids actually make matters worse for us in COVID? Well, here is a graphic presentation of what really happens in COVID. And so we're going to look at it. This graph is a little older. I think some of the graphs would be somewhat changed now because we have better information. But just to understand, when you get COVID, initially there's viremia. And in majority of the people, between 7 to 11 days, this viremia will start going down. In fact, if you're normal, most of the viremia disappears about 7 to 11 days. In HIV patients and patients who are immunosuppressed, we see this viremia go up to 21 days and then disappear. But what also happens during that time, and we did this ourselves, we did bloods on every patient that was getting monoclonal antibodies for 7 days. We drew bloods on every one of them, and each day to see what was happening. And what we saw is exactly this. We saw B cells completely disappear from the peripheral smear. So there's profound lymphopenia in the first 7 days, and it persists. And the more lymphopenia you have, the worse the outcomes are, and that's well known. Likewise, the T cells also begin to drop as the virus, so it starts here, and by the second, third week, the T cells are completely dropping off. And this is the phase between 7 and 21 days beyond. So now you have no lymphocytes at all, you have no T cells at all. This is when you're getting mucormycosis. So if we can somehow improve the lymphocyte counts to come back, or the T cell counts to come back up, we should see less and less of mucormycosis. So in what way are we harming it? So if we were to give steroids as we should, around 7 to 10 days, we could at least not prolong this viral replication, because the more you do viral replication, the longer the suppression of T cell and lymphocytes would be. So here, I think, is one of our protocols in India that we need to be vigorous about. So we are starting steroids from 3rd day, 4th day, 5th day. What you're doing then is this viral replication will go higher, the suppression of lymphocytes will be even more profound, and so would be the T cell responses, and the shedding will be much longer also. That's presumed, not proven, but that's what would happen. And maybe that's why you have much more substantial decrease in your T cell and lymphocytes, that you're increasing your chances of having mucor. So this is under your control. So when you start steroids and how long you give it is entirely under your control. So I would urge you to move away from using earlier and earlier, and move only when you see hypoxia. And the next one is the question of iron load. The reason why this has become intriguing for me is that mucormycosis always known to love iron. It actually feeds on iron and it grows on iron. And therefore, if we know for a long time that if you have iron overload like hemochromatosis, especially hemochromatosis patients who are getting deferoxamine, which is a chelating agent and frees up a lot of ferric ions, they get profound mucormycosis because the free ferric ions are actually particularly favorable for mucormycosis to grow. So the point I'm making here is, why are men getting mucor and not so much women? There are 2 reasons probably. Iron overload is more common in men than women. Number 1, that's well known. 2, the bacteria, the fungal genomics also tell us in mice model that male mice, you do knockout genes of males, these male mice, which can you can create spontaneously decay in them, and you can also increase their ability to get mucormycosis by knocking out specific genes. And when you study them, you found males mice are more susceptible to mucor than females. However, when they get infected, but eventually females will get it too, once they get infected, there's no difference in outcomes between male and female. It's just that the male are more susceptible to get it. And the second thing that's also significant is that the amphotericin B that you use is exactly responds the same way regardless of gender. It's just that the male are more susceptible to get it, but not more likely to, the outcomes don't change once you get infected. And then the last one that I want to comment on before we'll take questions is that We know now that there is a single receptor through which mucormycosis will get in, which is called GRP78 or glucose-regulated protein. And this protein is on cells, endothelial cells and mucosal cells. And wherever this protein is expressed, that is how, just like coronavirus gets in through the ACE receptors, mucormycosis gets through GRP protein 78. And no other fungus actually uses this receptor. Only the mucormycosis use it. I wish we had a chemical that blocks this receptor, then we could easily treat my mucor. We don't. But the second important point is how much of this receptor is expressed in cell is dependent on, number one, the pH. So the more the patients have DKA, the more acidic the pH, more GRP78 is expressed. So that making it favorable for the mucor to get into cells. Likewise, both iron, ferrous or ferric, the more the levels are, the higher the expression of GRP78. Another reason why mucor will get into a person relatively easily. And the last one is glucose. Higher the serum glucose, which most diabetics and all people who are getting steroids will see, the more the expression of GRP and the easier for mucormycosis to get in. So until we know more, this is my observation of how we should go about doing what we can do to prevent or limit the number of patients who will get mucormycosis. So the first one is limit. So the T cell response, as I told you, will be profoundly suppressed in severe COVID infection. And so we want to limit the viral replication as much as we can. There are only two things that really decrease or can influence viral replication. One is if you use steroids, it increases viral replication if you use it early. On the other hand, monoclonal antibodies are the only ones that we know can substantially decrease viral replication, which are not used in India yet. But when you use it, you will notice it. If you ask me, does remdesivir does it? But firstly, they were never done in early viral replication. Number two, it never really suppresses viral replication adequately for you to see change in T cell responses. You have to completely knock it out like the way monoclonal antibodies do, which make the viral loads go down to be almost disappear totally or up to 90% reduction. If you could do that, then T cell responses would be different. Steroids, so I would avoid using early. Number one, I would limit doses and I would limit the duration. So I wouldn't use it in the first 1 week. Second, I wouldn't use more than 6 milligrams of dexamethasone a day. And last, I wouldn't use it more than 10 to 14 days max. The next one is, I've noticed that many patients get multivitamins in India. And unfortunately, multivitamin capsules in India have iron supplements in it. I think you're feeding the fungus. So any infection, you shouldn't be giving iron supplements. There are many bacteria which also feed on it. So if you're giving patients multivitamins, firstly, I don't know if there's any value to it. So I think you should altogether forget about giving multivitamins. But if you're giving it, make sure you're absolutely sure it does not have iron supplements in it. The second one I want to mention is, why are men getting more? Obviously, alcohol consumption is more in men. That increases secondary hemochromatosis. I mean, the iron burden substantially is higher in people who consume alcohol. We've seen hepatitis C to be another cause. And in fact, in our data, I went back and looked at it. Hepatitis C was a risk factor that increased deaths in COVID patients. So therefore, in the last 1 year, as you lock down the country, consumption of alcohol is substantially increased in India. So you created another risk factor for mucor to come further down the line. Now, what about vitamin C? I mean, I have advocated vitamin C. I no longer will, because vitamin C will increase the amount of free ferric ions in your body, and I don't think that's useful once you are now susceptible to mucormycosis. Indeed, in some critical care units, they give intravenous vitamin C, heavy doses of it, without understanding there may be downstream implications of giving this. And if you're on a vegetarian diet, as opposed to a non-vegetarian diet, vitamin C has a profound influence on it. So vitamin C, if you take large doses, typically they're taking 1,000 milligrams a day, and you take a vegetarian diet, it absorbs all non-meat vegetable iron that's in your diet. As opposed to meat-containing diet, vitamin C doesn't seem to influence meat-containing iron that much, but vegetables that have iron, like spinach and all the green leafy vegetables, it will profoundly help its absorption, which is not helpful here at all. As I showed, glucose increases GRP levels, so therefore a tighter control of diabetes is necessary. And finally, I went back and looked at our own patient population, and they had many of these. They had steroids, they had iron overload, many of them were alcoholic. They're fairly common to see diabetes in them. And then why are we not seeing that much mucor, although we saw other fungi? And that's because the way we did in terms of operations in our hospitals, we use a lot of ultraviolet C light. So what happens in our hospitals is once a COVID patient comes in, he or she is discharged out of the hospital, the bed is cleaned, and then the room is closed for 1 hour, and we expose the room to UVC. Ultraviolet grade C-type completely destroys everything, destroys COVID, destroys all fungal spores, and kills almost all bacteria. So maybe because we did that, we did not see mucor or related opportunistic infections. And maybe it's something you want to see. You may want to look at least in rooms, if not wards, to use UVC light each time you empty a patient out for a new patient. This is the easiest way to kill mucor. And then medical devices, you have to find simpler ways to clean your nasal tubes, masks, and whatnot. Two things that work very well against mucor. One is soap and vinegar. It's so easy to get rid of this spores from tubes, like plastic tubes of any kind, nasal cannula, mask. All you do is to soak them in soap and vinegar, or you can use 10% bleach to clean them. In the United States, we dispose them off, except when they were getting home care, and we don't know what patients were really doing it. But it seems in India right now, you have to reuse them. So I would use soap and vinegar, which is very easy to get and use. And if you can get 10% bleach, that's fine. The only concern is if you use bleach and you don't wash it off properly, you could get chemical injuries from it. So that's why I'm worried about bleach. Soap and vinegar, on the other hand, is pretty much easier to use. So I'm going to stop sharing, and from now, that's all I wanted to say about what I would do with COVID. And we're going to go back and look at our iron studies and see what else we have to do. So I'll take questions now. I'll start with what I think I am. I'm moderating it too, so I'll read the questions myself, and then we'll take it from there. So the first question is, did zinc supplementation in a doctor's prescription lead to fungal infections? We have no data that zinc is harmful. And the point I was making is iron is harmful for mucormycosis. Zinc at best I would give only if you have a patient who's COVID and has profound diarrhea. And I would limit it to 25 milligrams and 3 to 4 days, not more than that. People take it, but it's a lot of nausea. It causes stomach upsets. You want them to take an adequate amount of fluids and oral intake. So I really don't think zinc has any value. But on the other hand, I'm not sure zinc is causing fungal infection. One faculty at Ames has tweeted, could there be lowered immunity because of COVID? And I think this was the point I was making, that there is profound drop in T cell function, both the CD4 type and CD8 type, and we measured it. So I'm not quoting somebody. These are my patients. We fortunately measured them at that time. Now I'm reflecting back and said I should have done a lot more patients. So I didn't even bother to look at this data, by the way, even though we had it. The last 3 days set me thinking and said, let me go back and look at it. And this is how you want to do. This is an emphatic yes. I think COVID suppresses your immune system quite profoundly. Can industrial oxygen be a cause of mucor? So first, 3 to 4 days ago, I had thought that your intravenous preparations would have been contaminated. I take it back. I don't think so, and I'll tell you why. So when intravenous liquids or steroids were contaminated, the disease presented totally differently. So as I was telling you, in the United States, intravenous steroids were contaminated with aspergillus. And what we saw was they got meningitis, they got abscesses in the liver. So when you inject stuff into the bloodstream, it doesn't only cause rhino-ocular disease, which is predominantly what you're seeing. So your contamination is not happening intravenously, even though you had some cases. Your disease is mostly mucosal. As I see it is in the nose or the ocular, and I've seen some GI tract. All of them are mucosal. We so far have not seen bloodstream mucor. Here and there may be cases. So I am less inclined to believe, as I thought a week ago, that it's intravenous. I take that back. I need more evidence to believe that's intravenous of any kind being contaminated. Does industrial oxygen cause mucor to grow? I don't know. Industrial oxygen is only liquid oxygen. I did not realize that it doesn't promote growth of the spores at all. The spores are ubiquitous. Oxygen doesn't do anything to it. It's not dependent on oxygen at all. So I wouldn't think that's causing it. That unchanged use of masks for long periods causing mucor. I think by them itself, it's not causing, although you're now creating, the spores are all over, so you letting them sit on your, very close to your mouth. So you kind of taking inoculum of the spores inside. But it still requires you to have certain other factors, which is steroids, low T cells, and maybe extra iron before you actually get disease. Let me answer. Dr. Budra, do you want to ask question while I can skim through these questions? Go ahead and ask or comment, or I don't know what you want to say.
Yeah, I think there was a gentleman asking a question about work on ozone prophylaxis, but I want to make a couple of comments.
Right.
So one is most of these mucor species have an enzyme called ketone reductase, which is what helps them thrive in high glucose acidic environments. Two is that question on zinc by Prem Kumar is interesting because you see a higher incidence of mucor in people who are getting the desferoxamine, the iron chelator, as well as aluminum chelators in some of the dialysis patients. And so I think there's some extrapolation as to these aluminum chelators, just like how it happens in aluminum chelators and iron chelators. Maybe the zinc has something to do with it. I think that's where the question is coming from. So those are the comments. And as far as the T cell immunity is concerned, COVID in normal people, induces a robust humoral response to the receptor binding domain, as well as a very durable T cell response.
Only if it's mild.
Yeah. So
when it's severe, the reverse happens.
Yeah. So most of these mucor infections happen. Very rarely they happen during the hospitalization for COVID. Most of them actually show up a week or two later. So in the transplants, in the solid organ transplant patients, we actually see mucors very late. I mean, after several months of immunosuppression, we rarely see them within a month or two of solid organ transplants. In BMT patients too, MuCAR is pretty late infection. It doesn't happen in the first 100 days most of the time. So I'm wondering if, what that means.
Yeah. What's the time period you get in solid organs, you said?
In solid organ, most of them happened, well past 30 days or 60 days, or sometimes even 100 days. So there was a publication in 2010 of a series of solid organ recipients. There were about 90 patients, and I think they had about 20 infections. And the mortality was about 53, and there was higher mortality in the CNS disease people.
Yeah. So I'll keep going with the question. Why does pulmonary MuCAR in hematological malignancy and rhinocerebral in COVID? So this is how fungal infections always work. As long as you have only T cell function, the diseases tend to be mucocutaneous. But the moment you drop your white cell count, or for that matter, neutrophil count, so if you have both T cell suppression and neutropenia, they become hematological. And that's what happens in hematological malignancies. They suppress everything. When they give their chemotherapy or bone marrows, they suppress not only T cells, they suppress white cell counts too. And that's why they get both pulmonary, they get seeding of MuCAR, they get MuCAR abscesses and all sort of that. What I'm proposing in COVID patients so far that we're seeing in India is that it remains mostly a T cell misfunction disease, not so much of the other cell. There is no real neutropenia. That we do see some neutropenia in COVID, but not a lot. I like to go back and see what is happening. This is the data I'm looking to from India. What is happening with your COVID patients? Are you seeing neutropenia? And I have one other in the treatment. This is key for us to have. If you know, Dr. Buddharaji, you know that you use colony-stimulating factors to treat. In addition, you give amphotericin B, you operate on them multiple times, take out the dead tissue, but you also will give granulocyte colony-stimulating factor each time if those numbers are low. Do they have a role in COVID patients? I don't know, but if someone tells me your COVID patients that you're seeing have profound neutropenia, I think you may want to give it. It's not going to harm them in any way. You need that extra push. You need the neutrophils to come up. You will give amphotericin B and you will be operating on it. So that's how I see hematological malignancies being totally different than COVID-related mucormycosis. What about voriconazole prophylaxis? So there appears to be actually a risk factor I think it's in your hematology that you identified that as a risk factor. I think in India, we don't know yet. I think voriconazole was used as a skin cream or something, and the All India Institute says, please don't take it because they saw some association. I don't know what the basis of why that would increase your risk. That's unclear to me. But it's only in India they're telling us not to do it. We don't have the information on it for me to comment. If anyone has information, please go ahead and comment on it.
Yeah, in the BMT and leukemia population, that's a well-known fact. The speculation is that it might be getting rid of the commensal yeast population, making way for invasive MuCAR. So the other question I had is, India, demographics, if you notice, they have high incidence of TB, they have high incidence of Hansen's, they have a lot of diseases that need good, robust cell-mediated immunity. Not so much in the general population in Western countries, except the target populations of solid organ transplants and BMT patients. So I wonder if that has anything to do with it, because of all the MuCAR patients that I've heard of about 15 patients now, none of them had neutropenia, at least when they presented.
Yeah.
And so neutropenia was not a big issue. So I'm wondering if there's some innate um, um, uh, lowering of cell-mediated immunity, pre-existing lowering of cell-mediated immunity just made worse by COVID, and probably induction of diabetes with steroids.
Yeah. It's possible. We know that there are certain genetic defects that cause you to have more severe disease unrelated to MUCAR. And there are actually MUCAR subtype, genetic subtypes who are more prone to get MUCAR anyway. So that's also well known. But I think this business of alcohol and iron, we need to go back and look at it. I think there are a fair number of men in India who have iron overload, and they're ignoring it totally. But anyway, let me, somebody's hand is up. Go ahead, Sudhakar first, and Dr. Pani something. I can't get your full name. Go ahead, ask, and then I'll come back to the chat box.
Yeah, Sridhar,
Yeah.
wonderful. That was a wonderful presentation. The questions that I have are, number one, how do we investigate these patients now, the one who have already presented with mucormycosis? Number one, to know that what led them to have this particular disease. Number two, do we have to revisit on those patients who are now suffering from COVID-19? With regards to the investigation, so that we can predict as to who are all likely to go, or rather which will throw some light on their prevention. So how do we investigate those who are getting treated now in the light of mucormycosis, and those who are already suffering?
Yeah, I think we need a little bit more information, but I think from what the data I'm looking at from my own database, and I'll go back and we'll have to do some more work to see how long this new. So I think if you find a male person who's diabetic, who really doesn't have adequate control of his glucose at the time of discharge. So this is happening after you discharge. So I'm seeing because most MUCAR is happening 21 days and beyond. That's what I'm seeing so far from the reports in India. Maybe some came as early as 20 days, but none of them happened in the first 3 weeks from the onset of COVID. So I think we would, if we can identify subsets of patients who had, firstly, they've had mild to moderate, moderate to severe COVID, that's number one. I would focus on men for the time being. Two, I would do iron studies and see, I mean, this is a fairly simple thing to do. Iron levels are easy to measure, and transferrin saturation or ferritin. Ferritin you're doing anyway, but it wouldn't be so dependable right now because any acute inflammation will raise your ferritin. So you want transferrin saturation if you can get. That will tell you that these patients have iron overload to begin with. Then if the diabetes, so don't go by hemoglobin A1C because for some unclear reason, mucormycosis does not follow hemoglobin A1C because for whatever reason, the current pH value and the current glucose is what it depends on. Hemoglobin A1C is really telling you how your glucose was 90 days ago. And MUCAR doesn't care what happened 90 days ago. It's looking for induction of GRP 78 now, not then. So don't bother doing hemoglobin A1C. But at the time of discharge, if the glucose is high, I would be worried about watching them. I would go that if I would want to say maybe we should try giving posaconazole for 2 weeks in these patients, but I'm not there yet. I think we'll continue to discuss more. Maybe we can come and try it on a few patients and see if we can study more and see if we more reliably predict who will get MUCAR, then I think we could do something like that. Somebody asked the question, is it possible? So one more thing about prevention. In the hospital, I would get UVC lights if they're not that expensive. I don't know how expensive they would be in India, but each of your rooms, wards are difficult to do, open wards are difficult to do. But I think rooms are easy to sterilize. I would do a lot of that, number one, if you can do. And I would instruct patients to wash their NG tubes and masks twice a day with soap and vinegar at home. I think it's a very easy to clean. They die very quickly on it. And so at least, as I said, the amount of inoculum you're getting is predictive of disease. So if you could decrease the amount of spores, I think that'll be helpful. Somebody else, Dr. Panindra?
Yes, sir. Yes, sir. Good morning, sir. Good evening. Sir, I am having some experience with HIV patients, being a fellow in HIV medicine. So I would like to have your observation regarding who are presenting with mucormycosis or also presenting with other opportunistic fungal infections or the spectrum of opportunistic infections as does the HIV population. For example, as you've mentioned, the CD4 counts are less than 500 and you have been seeing them below 200 and below 550 also. During the below 50, we come across coccidioidomycosis, cryptococcosis, toxoplasmosis, more so. So many cases I've seen in CMC Vellore during that period and have found about the mucormycosis. So my question is, in these patients, have they presented with other opportunity set of spectrum of the infections, like they are right from the bacterial pneumonias, or the PCP, or the fungal infections, or the lymphomas. So in this spectrum, what I found is this mucor, in your observation, is seen quite early. What with not much fall in the CD4 counts. So what's your observation? That's number one. Number two, sir, I'm really unhappy about why the CD4 count is very, very low, as in akin to in HIV. So there we have the cluster designated cells which are really susceptible for HIV. Whereas in the COVID, we never see that the T cell is directly involved in the form of depletion directly due to COVID. So what is your observation, sir, in these two aspects?
So I think this is why humility is very important. So we thought it doesn't affect it until somebody measured it. So that's why we fortunately measured it. And when I saw it's profound, then I went back to my Italian colleagues and hey, you have any T cell studies? And they had 100 patients, all of them uniformly. It suppresses T cells, both CD4 and CD8. It is like hyper HIV infection. There's a profound drop. Even HIV doesn't do T cells of less than 20 and less than CD4 and CD8 of less than 20 in a matter of 2 weeks. Even HIV doesn't do it. So this is a virus which is doing it. We didn't realize it was doing it. Now we know, so we need to go study it. Somebody asked me, would you do T cell studies for every COVID patient? If they're cheap in India, they should do it. But in the United States, they're relatively cheap. So I just wrote to my lab director, I'd like to order T cells on every COVID patient. Is that okay with you? And he said, yeah, go ahead and order. It's not that expensive. You just have to ask the patient consent and we'll take it. Now, the second question, do you see opportunistic infections? So fortunately, I was able to look at T cells on those who survived. I mean, so they had a normal T cell, got COVID, they dropped substantially, survived the illness, so they didn't die. Although they had moderate to severe illness, they survived. And within 3 weeks, all their T cells went back to normal. So whatever that dropped in T cells appeared to be about 3 to 4 weeks. That's what happened. So they hit the bottom around 21 days after the onset of infection. And then you have about 4 weeks where it'll come back up again. So I think that 4 weeks, from that 24 to another 4 weeks, is where your risk of getting mucor is the highest. So in that time period, if we can, number one, not divine, knock off the steroids, and maybe try antifungal prophylaxis, worth exploring. But again, it's going to be the way I see it. If a drug is giving you adverse event, don't come up with another drug to treat the adverse event. Just get rid of the drug which gave you the adverse event in the first place, right? So yes, maybe it's so rampant now in India that you may have to think about prophylaxis in severe patients who you gave large dose of steroid, maybe in them, for not more than 4 weeks. I think that's all you will need because we saw T cell bounce back. We'll do more data analysis of what we have, and I'm going to ask the Italians to see if they will look more. This is limited numbers that we have. Actually, no university hospital. Mount Sinai, I asked them how many T cells you have in HIV or any T cells in COVID. They had none. They couldn't come up with any patients. When I said I had 50, they said, "Whoa, you have the most data. Why don't you write it up?" And I never saw it. I'm going to sit and write on it. So, but let me take some more questions. I hope I answered yours.
Yeah.
So we don't see any because it's so transient and it's only about a month and then they bounce back. Dr. Prem Kumar.
Yeah, good evening,
Thank you,
Sridhar. Good evening, all of the US. See, if the immunosuppression comes to the fore, we have been giving steroids, mycophenolate mofetil, tacrolimus, and all those things to suppress the T cells in organ transplants, especially the renal transplants and all. In all such cases, we are seeing mucormycosis so rampantly, or only why in COVID era we are seeing more. And the second question is, the observation is mucormycosis is rampant only after the NK440 variant came in. So does it do anything with the variants which cause more immunosuppression or anything like that? And why we didn't see them so rampantly in the first wave when the NK440 strain was not there? Is it that the less numbers in the first wave that could be the central reason? These are things.
No, I have a theory. Again, it remains a theory. It needs to be proven. Why was it? Firstly, there's no evidence, at least currently, that the variants present any more severity disease as yet. What the variants done is substantially increase the number of people who got infected. So that happened in Europe and happened in South Africa, happened in Brazil, and then happened in India too. So I don't know if the variants are doing something different. But in your first wave, you didn't consume that much alcohol. Let's not ignore the amount of iron overload you're creating. But in the second load, you have consumed a lot more alcohol, so that your iron loads are much higher now than before. I know nobody likes to hear that, but I'm saying it may have played a role. It is not clear now that it's the Indian variant that spread all over the world in India yet, number one. It's not clear that that's the one which got mucor either. That's your assumption. We'd like to see some genotype to say that the majority of mucormycosis was the Indian variant. I don't think so. I think it's probably quite a bit of UK variant and quite a bit of Indian variant. I don't think it's one variant causing mucor because immunologically it doesn't behave that way. Your disease is behaving exactly like severe disease in Europe, in South America, North America. It's not behaving in any way differently, as I see. It kills the same way as it's killing everything anywhere else. Let me take a few questions on the chat and then I'll come back to you. What's the best investigation, either CT or MRI? CT is pretty sensitive. The first thing is you need to, the index of suspicion has to be high because often it's missed. Even now it's missed, even though we know about it. So I think in the second week of the, about the third week of the illness, the earliest, the overt signs everybody can pick up. But many of them will get just some puffiness of the eye and some congestion. That's all they have. And if you're on a chronic ventilator, many of them have puffy faces and it's very subtle, so you would miss it. So I think it's still a clinical suspicion that needs to be fairly high. Your index should be fairly low. So moment you see some congestion around your orbital area, you say, hey, this could be it, and order a CAT scan. It's pretty good. You could do MRI, but the patients are relatively unstable. So CT is fast and fairly easy to detect. So that I would go with CT because it's faster than MRI. It's not necessary that you must have an MRI. In the background of non-availability of liposomal amphotericin B, what would you use? So number one, liposomal is optimal, but if you don't have it, I go back to my residency days. and fellowship days. Amphotericin B, when liposomal came, it was extraordinarily expensive even in the United States. So what we would do at that time was we would still use the traditional amphotericin B, but I would mix it. We would have this kind of, what we do is we have 2 bags we would hang. One is the amphotericin B, the non-liposomal. I hope you have that. And then the other bag would be liposine, or you know, the total parental nutrition, the fat emulsion that you would use as part of your total parental infusion. I think in India it's called intralipid. I think that's what they call it. In the US we call it liposine. So 25% liposine is fat emulsion. It's an intravenous product used for total parental nutrition. We hang both IV lines at the same time, and it more or less they mix inside the bloodstream. What they do is it decreases substantially the amount of thrombophlebitis that you get when you use the other amphotericin B. What it doesn't prevent, on the other hand, the renal toxicity. The liposomal is fairly good at avoiding renal toxicity. Unfortunately, the non-liposomal will give renal toxicity. So therefore, you may have to monitor amphotericin levels in them if you have to use that. Other than that, you have to use oral preparations like posaconazole if you have it, and try that. But remember, it's not just amphotericin B. It is a substantial amount of importance is the surgical debridement. The surgeon has to go multiple times and take off all the dead tissue. Every little dead tissue has to be removed. This amphotericin B will not save a person, so you need to do that. And I think you need to look at the neutrophil count and see if you want to give colony stimulating factors. I'm gonna go through. Can mucormycosis transmitted from one patient to another? No, it doesn't. You don't have to, because it's ubiquitous, it's everywhere in the air. It's just waiting for a nice host who is immunocompromised to grow. So it doesn't need another patient. It's there all over. So, so no, it's not transmitted from a person to person. So again, the second wave question is asked often enough. I think the number one is you have substantially more number of infections now than the first wave. Your systems are substantially compromised now also. You're reusing a lot of catheters. You're not really controlling diabetes that well because you're overwhelmed, and I understand why it's happening. So you have mitigating factors that have crept in. You've developed a protocol where you're giving too much of steroids. So some of it is the virus and the numbers that scale are too high for you to manage, and then things that you did that may be harming. So therefore, I was just saying, oh, somebody asked me, what should you do in India in the first week of COVID infection? Number one, I would give either Tylenol or ibuprofen for fever and body aches. If I want to give vitamins, I would be absolutely sure that it doesn't have iron in it. I would carefully manage the underlying conditions, which is diabetes. I would control it well and not keep glucose levels too high. And in the second week, if the patient becomes hypoxic or develops encephalitis or toxic delirium, I would then start dexamethasone 6 milligrams or its equivalent and give it and watch it every day. If he or she gets better in 3 days, I would stop it. The other day, somebody asked, do you have to taper it over 3 weeks or so? Not at all. I think if you're giving somebody 3 days, they do well, and everything is gone, you could just stop it and watch them. Don't prolong it if you don't have to. Use it exactly the number of days you want to use it. I think tight control of sugar is important. What else?
I think
yeah,
so I think Prem had a question, but before that, I wanted to reiterate one point. Is sorry to interrupt. But in
No,
this
no, go ahead.
in the retrospective study that I was mentioning of 70 solid organ recipients, the
Yeah.
key issue was the mortality was almost twofold if the amphotericin B was delayed by 6 days from diagnosis. So the mortality was 83% in people who got started on amphotericin B 6 days after diagnosis versus 49% on those who were started before 6 days from diagnosis. I think that early diagnosis is the key, I think.
Yeah. And you put the point about serum iron levels. So this is relatively easy to get. Sudhakar was asking, what should I do at the time of discharge? If T cells are easy to do, I would start doing them because I'd like to know when I'm intellectually curious about what are the T cell responses in India, because we have paucity of information from India. Even in the United States, we don't have one. In fact, when we'll write out the series up, it'll be probably one of those first ones which had T cells before and after. I agree, more men, it's because of iron overload. That's what you mentioned from the other paper. If posaconazole also not available, what will I do? I don't know what to do. When you run out of amphotericin B, you run out of posaconazole. Then I think and you already have then at least what I would do in that situation, here's what I would do. I have to give you an answer. So I would ask the surgeon to thoroughly debride and maybe give colony stimulating factors and see if that helps. That's what I would do, because you can't say, we got nothing, you just die. We can't say that. So I would debride the wound and control the sugar tightly and maybe try colony stimulating factor. Hopefully you have them for the time being, and hope that you will get amphotericin B as quickly as you can. Somebody asked about zinc, and I said we went over that. Ventilators used for Mucor, what measures to be taken to use it after you use it on other patient? Maybe Prem, you want to answer that one? How do you clean your ventilator?
Which one, sir?
How do you clean your ventilators after you use on a Mucor patient?
First of all the surfaces of the ventilators, even the monitor, will be cleaned by 1% hypochlorite on the surface. And then we replace the tubes. And we have issued orders that every day we have to remove the humidifier, and which should be washed with a mild soapy water and clean, and then keep it. And it should be topped up to the marked level. That's all.
Yeah. So my additional suggestion is have a room, put a UVC lamp in it, take the ventilator, leave it there for 30 minutes or maybe an hour. It'll kill everything. I agree, you should do all the things you just said, clean it, use all that. But the easiest way to sterilize a ventilator is leave it in a UVC room. It doesn't damage the equipment at all. But you can't go in, it's damaging to your eyes. So you can't go into the room. The room has to be like a locked room, and you can put 10 ventilators in, leave them for 1 hour and take them out. This is what we did. It was the easiest way to clean them. By the way, we had no ventilator related pneumonias, infections, nothing, even though in the massive surge, never had problems in terms of infections with it. Earlier, Panindra, I think he asked me a question about what other opportunistic infections or stuff we saw. So I went back. I mean, again, I went back because of what is happening in India. And we did find in the 3-month period from March to June, a higher rate of E. coli bacteremia, which we never saw the previous year. So I compared 90 days of 2020 to 90 days of 2019. All things being equal, there was a significantly higher rate of E. coli bacteremia, which we hadn't seen it before. And I didn't even notice it. Now, I just saw it this week, and we started looking at that data, and I've noticed that. So I think there is some bacteremia associated with this profound suppression of T cell function. I just want to mention that.
Dr. Sridhar, can I put forward a few observations of mine?
Yeah, go ahead, please.
actually, when the mucor is becoming rampant, I thought what we have done differently or which way our people are different. So I observed a few prescriptions, outpatient prescriptions and inpatient prescriptions. Outpatient prescriptions, what we are doing is using in every case doxycycline, and some people are prescribing doxycycline plus azithromycin, 5 days, 7 days, 10 days. Even in mild cases, which would have been become normal even if you didn't do anything. That's one. And a few prescriptions have shown even the third day steroids were started. And steroid means Medrol 16 mg twice daily, thrice daily. And what other thing I observed is in the inpatient and Fabiflu, the favipiravir was used very rampantly. That was one thing we did differently. And then the IP inpatients, the day one piperacillin tazobactam or meropenem was kept for severe pneumonias. That's one thing. And solimedrol 500 mg 3 days pulse dose, a lot of people are even today giving. That's another thing what we have done differently. And probably the cleaning and disinfection of the equipment, disposables, consumables, that could be one of the reasons we are difficult to do it here in this large scale patient presentation. And so these are some of the observations, which way we made, or our people are different. People, hygiene is a problem, or poor people are using the unwashed cloth masks for several days or even months, the rural people. Could it be a reason? Or people in rural area where, this is more, they're involved with agricultural work and all, could it be the reason? So these are all the things what I observed. Were we different, or were we doing things differently, or what it could be? So whatever I put forward, could you comment on any of this could be the culprits, or we really don't know? And last point I forgot is, after discharge, people are prescribing solimedrol for 3 weeks. See, if the patient is discharged with residual fibrosis on a CT scan, they're prescribing. If the patient is
go ahead.
If the patient is hypoxic and we had to discharge the patient with home oxygen, they are kept on steroids for 3 weeks. Like that, if the patient is not okay at the time of discharge, the steroid prescription is on for 3 weeks. So these are all the things I observed what has been done differently here. What are your observations about this?
I think maybe you missed my first half of my talk. You kind of pointed exactly what I was saying. One is I comment about T-cell responses. I said by giving steroids earlier, you increase viral replication and worsen the total amount of T-cells available. So you suppress it even more. You cause T-cells to exhaust themselves. And I think that's the first mistake we're making. And I also said that you don't want to, you also want to limit your dose. I said 6 milligrams is no data at all. Higher doses are useful. And you've already seen all over India, you're harming with your higher doses. And lastly, duration. I don't think we should ever exceed more than 10 to 14 days. If it's going to work, it's going to work. After that, it just won't work. After that, if you still have persisting, it's probably a hypercoagulable state that you have to handle, or a secondary bacterial infection that you want to handle. So in terms of hygiene, I was saying if you could use UVC light, that would be great. But otherwise at home, the easy one is to use soap and vinegar, or 10% bleach if that's available. Whichever is available, you should use. Alcohol swabs don't kill mucor, so don't bother using alcohol at all. Soap is the best way to kill spores, and so is vinegar. So that's what you want to do. So I agree with you. I think it's not a single reason why it has come up. It's a multifactorial that caused all of them to happen at the same time. In terms of what can we do in terms of prophylaxis, there are lots of questions here. Firstly, I don't know if you have enough of antifungals to give currently that are effective against mucor, which is only posaconazole other than amphotericin B. If you have enough doses, that's one thing. So rather than do that, you could try something lactoferrin. I think lactoferrin pills are available. They kind of limit the amount of free iron radicals available for the fungus. So that could be something you could try, apart from tight control of your sugar and stopping steroids at the time of discharge. Total stop. I don't think you need steroids at home at all. So I think the observations you made are all, and all of them, it's like a perfect storm that came in, and you're seeing the end result of that. That's basically what's happening, I think.
What do you say about the antibiotic uses in the early stage, both the doxycycline and azithromycin? A lot of people are using, and the day one in IP, people are using Pipjo and Mero.
Yeah, I absolutely, this should not be used because, again, so I went back, we did hundreds of respiratory cultures, bloodstreams, never grew anything in the first 3 days of infection, never. Almost everything that grew were in the 3rd week of admission. So bacterial infections, if they occur after at least in the 2nd or 3rd week of the disease, from the point of first day. So if you're hospitalized, probably in your 2nd week of hospitalization, maybe if at all, they may happen, not in the 1st week at all. So there's no reason to give everybody azithromycin and doxycycline. Now, you are increasing your chances of getting candida. I mean, don't always worry about mucor. Candida is also a problem for you. We saw 10% of the bloodstream infections were candida post-COVID. So it's not a minor bug to ignore. So it is there. So you keep giving broad spectrum antibiotics, you'll end up with, and then add steroids to them. It's a perfect mix for candida to grow. So I wouldn't give them either. I agree with you.
Sridhar, one question, Sridhar.
Yeah.
This is Dr. Malampally. I'm one of the consultant anesthetists and intensivists. As Prem has just rightly pointed out, people are erroneously using methylprednisolone and dexamethasone forever at their own choice, and they are killing the people with the steroids. So my first question to that is, do you use methylprednisolone or dexamethasone? What is your first choice, and how do you choose in between them? And number two, as you're right, in UK, we only prescribed 6 milligrams of dexamethasone only for a period of 6 days, and then we stopped. Here, people have no clue and no idea of what to use, and they're using erroneously the steroids, and they're, as Prem rightly said, they are even continuing the steroids. So can we uniquely form a guideline and publish? At least Prem is the head of the department there, and I think Prem can definitely circulate a circular with the government, and then at least put it on the newspaper and then say, this is what that's being happening, and please do not use the excess amount of steroids. So
I think he did. I think there is a protocol.
No,
Actually, the protocol is there. Now, what we are mulling about is to, start a pharmacovigilance committee, and this pharmacovigilance committee will visit the ICUs and, certain clinics, and we'll audit the prescriptions. Now, if there is any indiscriminate use of steroids for prolonged period of time, see, initially we advise, then we request, then finally the reprimand comes into place. So now the pharmacovigilance is the only option left out for us.
But when do you use methylpred and when do you use dex? What is?
I think in India,
is there a clear criteria in between choosing the patients in between these two steroids?
No, the problem in India about which, no, so in India, I don't think they have a choice. There's a limited amount of steroids available, so they use what is readily available. So you can't choose in India because of short supply of medication. So ideally, the study was done with dexamethasone and prednisone. Those were the studies done. Methylprednisolone was also allowed to be used if you don't have what you want. I think India, I understand that they cannot get dexamethasone adequately in India. So they are using alternatives. And I'm okay with it, as long as the doses are reasonable.
And how about in pregnant ladies?
In pregnant ladies, my personal preference is prednisone. And the reason why is how it penetrates the placenta into the baby. So prednisone has the least amount of penetration into the baby compared to dexamethasone, which completely goes into the baby, and you don't want to harm the baby's lungs. So that's why in pregnant women, I have a particular preference that it should be prednisone.
So I wanted to respond to Dr. Srinivas Rao's query. So in all the forums, in the ICMR guidelines, in the state government issued guidelines, in the local guidelines, and across all our forums, including this one, we've been repeatedly warning against using higher doses of steroids and sticking to dexamethasone 6 milligram equivalent for no more than 10 to 15 days, unless there's a compelling reasons like coexisting airway disease or something else that's prompting them to use escalated doses of steroids. I agree with Dr. Srinivas Rao that even today, I have seen a couple of patients in some of the corporate hospitals where they were using 125 milligrams of Solumedrol twice a day IV for somebody who's well past the cytokine storm. It is a challenge convincing people not to escalate steroid doses. And I think Prem was coming up with an idea, if for whatever reason, for deterioration of oxygen status or saturations, if you're stuck with needing to escalate steroids, a reasonable alternative would be to use something like baricitinib in association with remdesivir based on the ACT-2 study, but that's a different point of contention. But we've been uniformly warning people, educating people across all the forums, and all the guidelines suggest that please do not escalate doses beyond, what is established in clinical trials.
Now, I must put it here in front of the forum, as Prem has rightly said, it's not 125 milligrams, sir. They are using 500 milligrams stat dose and then 250 milligram BD. That's
yes.
I have seen
even
in hospital, corporate hospital prescriptions.
Even as high as 1 gram. I've seen even 1 gram.
And then 125 milligram BD for heavy length of time they are continuing. And then no wonder why people are, getting black fungus or whatever it is. Even the fungal infections, just the normal candidiasis, I've seen more than 10% as right just Prime, I think Sridhar has pointed out.
Actually, I forwarded a message to Dr. Sridhar that someone in the WhatsApp is circulating, a learned doctor, that the house is on fire and we are dousing with a small trickle, and it should, what do you call that? Drip irrigation. He mentioned we are treating with drip irrigation steroid. We have to use the fire engine hose to extinguish the burning, house. That's what he said. The inflammation is raising, and you have to extinguish with such a large dose comparable to a fire engine hose. I don't know what to comment on.
And I don't disagree with it at all, but you should be putting fires out with water. What you're doing is you're putting gasoline, and that does not work no matter how much you put. So you got to use water to put out fires, not gasoline. 1,000 milligrams of whatever steroids you're giving is gasoline to an infection, and you shouldn't do that. That's my point.
But
okay, Sudhakar, do I stop now? It's 10:30.
Yeah. It's time. It's time that I think we should call it a day.
Yeah. So just to before we end, I want to emphasize those that we can do, we should do. That's my point again. Limiting steroids is good. Avoiding viral replication by mistiming the steroids is useful. Controlling diabetes, using insulin. You have to use insulin. There's no other way to control is useful. Check the multivitamins. Do not give iron at any cost. And I would stop giving vitamin C altogether in India. I don't think you want to do it in so much of mucor. And finally, you could use lactoferrin. That's available as an oral preparation. If you feel you have patients who may be at significant risk, At the time of discharge, we could give lactoferrin. It kind of decreases all the free iron levels that are available for the fungus to grow. It's completely harmless, so that's something I would think of trying. We've never used it. I'll caution you. So I don't want to start a new quackery or something like that. There's science behind using lactoferrin. That's all I meant to say. If you have a person with very high iron levels at the time of discharge, who's diabetic, who had severe COVID, did steroids, has poorly controlled sugar, I would certainly consider giving in them and maybe antifungal prophylaxis. So with that, I want to stop now. Sudhakar, any last words, and then with
Thank you very much, Sridhar, for that excellent not only presentation, but the way you have conducted the discussion as well. And I can see a lot of contribution towards how to go about this particular infestation in future. So we have a lot of, I have made a note of all that you have said, and probably we'll be going in the direction to prevent as well as to work up these patients in future. And I'm sure that this has thrown a lot of light today, and it's the need of the hour as we are facing with a lot of this